Hey guys, welcome back to the Pulling Curls podcast. Today on episode 131, we are talking about ultrasounds. Totally black and white. Let's untangle it. Hi, I'm Hillary Erickson, the curly head behind the Pulling Curls podcast, where we untangle pregnancy, parenting, home, and even travel. We know there's no right answer for every family, but hopefully we can spark some ideas that will work for yours. Life's tangled, just like my hair. Okay, guys, before you get started, you know what else is black and white? Leaving me a review. There should be no question in your mind about how exciting and important it is to leave a review for the Pulling Curls podcast on Apple Podcasts. Thank you. Today's guest is actually a friend of mine from my daughter's school. She is an ultrasound tech at a high-risk perinatologist office, and she is on Instagram, on TikTok, on the username Sono.Eyes. She has all this information about ultrasound, so I want to introduce my friend, Marybeth. Do you feel prepared for your delivery? In just 3 short hours, you can be prepared for the confident, collaborative delivery you want. You'll know what to expect and how to talk with your healthcare team, and there are no boring lessons in this class. I'll use humor, stories from my 20 years in the delivery room to engage both of you. I love how Alyssa told me that she found herself laughing at things that used to sound scary. Most of all, you guys are going to be on the same page from bump to bassinet. Join the online prenatal class for couples today. You can save 15% with coupon code UNTANGLED. You can find the link in the show notes. Hey, Marybeth, welcome to the Pulling Curls podcast.
Hi.
Now, Marybeth and I, we know each other from school. We knew that we ran in similar circles back in the day.
Yeah.
Like, we weren't in school together. Our kids were in school.
Our kids. Yeah. Our kids. Yep. Our daughters.
Yeah. But she knows all about ultrasounds. And I have to tell you, a lot of people are like, Hillary, here's my ultrasound. Can you look at it? I'm like, that's an ultrasound. It's got that ultrasound shape to it.
It's black and white. Yes. Looks like an ultrasound.
Oh, that's beautiful. And they'll be like, do you know what gender it is? I'm like, that could be an umbilical cord or it could be genitalia. I'm unclear.
Yeah. Yeah. I can see a foot. That's it. Right?
Yeah. It is not the labor nurse's forte. So that's why we have ultrasound techs. So let's just explain quickly, like, what is your job?
I'm currently a stenographer with a maternal fetal medicine practice. So that means if you are deemed high risk in your pregnancy, then you would come to our office or a similar office, and you would have an ultrasound and you'd meet with a maternal fetal medicine specialist or a perinatologist. So they are OBGYN with an extra emphasis on maternal fetal medicine specifically.
Yeah, we call them the high risk OBGYNs basically when we're trying to talk to patients. And your job is to do the work to get the pictures, basically, right?
Right. So as a sonographer in a maternal fetal medicine practice, we work really closely with our doctors. So if you come to our practice, we have certain protocols, certain things that we need to get. We work really closely with them. So we kind of start, the sonographers at a maternal fetal medicine, we have a lot more training and a lot more education. So if you are deemed high risk, you would come to one of our offices or an office similar, and it's just a much more detailed exam. But our doctors just have more education on problems with the baby and maternal problems. So if you're deemed high risk because of the fetus, either like, for example, the baby's small or the baby has a chromosomal abnormality, you would see a maternal fetal medicine specialist. Or if, say, you have high blood pressure or you're diabetic, then you would be deemed high risk due to maternal factors. So as sonographers there at a high risk practice, we just have a lot more training and education on how to give you and the baby the best care during the pregnancy.
Yeah. And you know more about which pictures to take versus just an ultrasound tech at the hospital that does appendicitis and babies and arms and whatever ultrasound.
OB itself is a specialty. So when you come into, like, pregnancy is a specialist, gynecology is a specialty, OB is a specialty, high risk OB is a specialty. So like, you wouldn't go to your GP for a broken bone, you'd go to an orthopedic, someone that specializes in that. So this is the same process as an OB. They're good for your general, everyday patients, not high risk. But if they need you, or if you need high risk help, then we're there for that. So we're more indication driven, meaning that you would go to a general OB, but if you need us, we're there.
Yeah. And you're the person taking the ultrasound. I think a lot of people think you then read the ultrasound, which you do not. I mean, you have a basic idea. Yeah.
I mean, you have to know what you're doing. So for a high risk sonographer, which is what I am, you do have to know like your pictures, they're much more detailed oriented. So like at your OB office, your sonographer at the OB office needs to know that your baby has an arm. Right? At a high risk office, I need to know that your baby has an arm, has all the bones in the arm, has the hand is attached, all the fingers are there, and then the hand opens and closes and it works. So now take that thought process and then apply it to everything else: the brain, the heart, the face, the abdomen. And so it's kind of like a way to level up all the detail on your baby's anatomy.
Yeah.
But yeah, as sonographers, like OB sonographers, they have a tough job. They have to know if something doesn't look right. And if they think something doesn't look right, then they would send you to us.
Yeah.
So that's how that works. They have a hard job too.
Well, and they're just seeing more people, lots and lots of people quickly.
Lots of patients and quickly. Absolutely. So
Yeah. So in the hospital, though, when we call ultrasound at the hospital I worked, all the hospitals I've worked at, it's just an ultrasound tech. So they do everything.
right.
They do trauma in the ER, they do appendixes, they do us. So it is very different. And then, we will call in the bigger guns if we need to. So,
I mean, a general ultrasound program teaches OBGYN. So in a general ultrasound program, you learn, thyroid, abdomen, things like that. But then you learn OBGYN. So most of the sonographers that are in hospitals, unless they specifically work under maternal fetal medicine, are general OB sonographers. So their goal, again, is to catch if something looks abnormal. That is their goal. So they also have a very hard job. But their job is to see, is something abnormal? Do I need to be concerned about this? But yeah, different registries.
Yeah. Also, we sometimes order ultrasound on baby, plus kidneys, plus liver, plus, so they do need to know how to do all the things. Yeah.
And when I worked in a hospital, that's what I did. We would do everything. So yeah.
Yeah. So do most of them start in the hospital, like with just your basic do all the things?
I think the majority of them do. I mean, like cardiovascular is a whole nother thing. So if you're only doing echoes, like adult echo, pediatric echo, you only go that route. But yeah, most sonographers start in a hospital or an outpatient imaging center. You learn vascular, you learn general, you learn OBGYN.
Yeah.
The majority of sonographers do. Yeah.
Okay. So today's episode, we're going to talk about just your basic routine ultrasounds that most people end up getting. And stay tuned because March is ultrasound month and we're going to jump to ultrasound testing that your doctor might order. Again, something more high risk, like we're talking about also. So, okay, your basic ultrasound, what ones do pretty much everybody get?
So I know overall ultrasounds, they can be intimidating. I think they're hard for most people to read and look at and understand. And sonographers, some of us talk a lot and some of us don't. And I think that I have found that when people are concentrating, they stop talking, which then you as a patient are like, is something wrong? And I just think that we're all different and some talk a lot, some don't. But there are certain protocols and certain things we look at depending on your gestational age. So most people do get an ultrasound in their first trimester. This can be anywhere from 5 weeks to typically 11, 12 weeks. So what are we looking for at that first trimester ultrasound? The first thing we're looking for is there a pregnancy in your uterus? How many gestational sacs do we see? Are there more than one? Is there a baby in that gestational sac? Is there a heartbeat in that baby?
That's the big one.
That's a big one. That's a big one. Is there a heartbeat? This should be measured by what we call M mode, which is just a motion mode. We're just measuring the motion of the heartbeat. The Doppler sound, we're taught we should not use in the first trimester because we want to keep any power that could go into your baby. We want to keep that as low as possible. There's been no proven effects from it, but we just don't want to expose your baby to any unnecessary power. So you may or may not hear the heartbeat at this time, just depending on your practice and what they do. We also measure what's called the crown rump length. That also is CRL. We use that. And that just tells us how big the baby is. We like to look at your ovaries. We would like one baby in the uterus, please. We do not want one in the ovary. And then we want to look at your overall uterus. How is the shape? How is the size? Any fibroids, anything we have to be concerned about. So that's what you're looking for in a first trimester ultrasound. Now, if you were coming in for like an emergency, we want to see, is the pregnancy viable? If you're bleeding, we want to know, is there a subchorionic hemorrhage? Is there a reason why you're bleeding? And if you're coming in for pelvic pain, we want to make sure that it's not ectopic, meaning it's in your tube or in your ovary. And we want to make sure that your ovaries look good.
Yeah.
So that's kind of your first trimester.
Now, a lot of people get this one at the OB's office.
Tons.
Especially if you're in
Absolutely.
a larger practice that has a machine. Not everybody does it. Some OBs will send you out for this, but a lot of them just do it in the office, mostly to make sure there's a heartbeat because
Right. And you're dating. Like this is when your due date is best determined, is in the first trimester. So there are guidelines for your dating. The dating is most accurate in the first trimester because all babies grow exactly the same in the first trimester. So your genetics do not play a role. So if you come in and you're under 8 weeks, if the baby is more or less than 5 days, we keep your due date based on your last menstrual period. We do not change it. So once your due date is established, that tells us how big the baby should be going forward in your pregnancy, what your due date is. So we don't keep changing it. It could be a couple days off. That's fine. If it's more than, say you come in, you think you're 6 weeks and you're really 10, well, then we would change your due date based on the ultrasound date, not your last menstrual period. And this is really helpful for people that don't have regular periods, that don't track, maybe people that have PCOS and don't ovulate regularly. This is really important as soon as possible to date you so that all your testing from that point on is accurate. And that's blood work, ultrasound, all of that. Some of it is very particular to how far along you are. So it's best to be dated and to know, is there one baby in there, 2, 3? That's when we find out multiples and we can manage your care from that point on.
Yeah, that first ultrasound is super important. I see a lot of people are like, maybe their doctor, saw a heartbeat in the office, but they want them to go in to get dated because the doctor doesn't do that in the office and they'll skip that. But it really is important just so we can know, if you have a problem in your 37 weeks, it's really different than a problem in your 39 weeks,
Exactly. Or 32 weeks.
We really want to know how far along you are, as accurate as we can be, because it just depends on so many things later on. That first one is so much better.
So important.
Yeah.
Absolutely. And then the further along you get, the less accurate your dating gets. So in your third trimester, we're not changing your due date because if you have a small baby, we then don't keep you pregnant longer to grow the baby. We don't keep you pregnant for a year, right? And if you have a bigger baby, we don't say, 30 weeks is fine for you, because then we just have a big immature baby. So we keep the same dates from hopefully based on your last menstrual period, confirmed with an ultrasound. And then that is our expectation of how big the baby is. And it really does make a difference at the end of the pregnancy. That's when I think it really, really matters. And unless you have complications, we need to know, how big is this baby supposed to be?
Yeah.
It creates a common denominator for us.
Or Mike, how developed? Because then that shows us, how our lungs. That's always our big one. Like, how are we going to breathe on the out of sides?
Yes, it makes a big difference at the end for sure.
Yeah,
that it can, absolutely. So that's really your first trimester. That's really what it's meant for. Is there a baby? How many babies are in there? Is it consistent with your dates, or what is your new due date, and how does the heart rate look? So that's the most important thing.
And it's pretty quick. I think a lot of people are like, it was really short. And I'm like, well, there really isn't all that much. It's tiny. It's a very tiny little thing.
There's really not. I mean, it's adorable, but really there's not a lot to do. There's no anatomy involved. It's just, is it there? Look at this cute little baby. That's what we hope for. Cute little healthy baby all the time.
That's every single hope. Yep.
Every hope. Absolutely. So that's normally like your first ultrasound up until about 12 weeks. Now, typically, a lot of OBs recommend the nuchal translucency or the first trimester ultrasound, and that can be done anywhere from like 12 to 14 weeks. This is a very timed test because the first trimester combined screen blood test, the baby can only be so big. So if you come in too early, you don't qualify. Or if you come in too late, you also don't qualify. So it's very specific around that 12th week of pregnancy. Most insurances that I know do cover this. Some people do blood work prior to the ultrasound, like a NIPT, a non-invasive prenatal testing, or NIPS, non-invasive prenatal screening. And that's for chromosomal abnormalities. Some people do the ultrasound with the first trimester combined blood screen. That's normally what happens, the blood work part with that ultrasound. But this 12-week ultrasound, this is when your baby really starts looking like a baby. They have this cute little profile, and their head and their body are proportionately sized, meaning like at the beginning, the head and the body are like the same size, like little gummy bears, but now they look like a normal human. So we see arms and legs. And I read somewhere once that at 12 weeks, the baby is the size of a Matchbox car. So, I mean, they're tiny, and it's amazing that we can see all this detail. But the test is so that we measure the skin on the back of the baby's neck, and that's called the nuchal fold. And so if their skin fold is increased, that increases your chance of having a baby with a chromosomal abnormality. So I like to think like at the 12-week ultrasound, we're hopefully able to rule out the big stuff. Is there a brain? Do we have arms? Do we have legs? Do we have any swelling around the baby? This can catch a lot of major abnormalities really early. So I really like this test. I think it's a great kind of intro to, is your baby progressing normally? Does your baby look normal? Do they look healthy? And it's a really good test to see that right at the 12-week time.
Yeah. And this is one that your mom, if she got ultrasounds, probably didn't do, because they just came out with it when I was pregnant with Paige-ish. So probably around 2007
Yeah.
was when it started.
I don't remember.
Yeah.
Mm-hmm. Yes. It's a new thing, but it is fantastic. And the more sensitive that our ultrasound machines get, the better these images are. So they're starting to see, new studies have come out that say if you're at higher risk for spina bifida, there might be something that we can see in the baby's brain at 12 weeks that would make us concerned for that. Whereas before we wouldn't see that until 20 weeks. So as more information comes out, more studies come out around this 12-week ultrasound, the better we get in diagnosing these big defects early.
Yeah. I know a lot of people don't want to do the nuchal translucency because they wouldn't abort either way.
Right.
They're happy with whatever baby God gave them.
That's great.
But it can also, as you said, it gives you just more time. Like if you found some issue with the spinal cord or something like that, then you have more time to make a plan as to what you're going to do after the baby's born. We're not saying that this is a reason to abort or anything like that. This doesn't have to go hand in hand with anything like that. It just gives you more information and more time.
Right. I don't ever think of this in that setting of this is a termination thing. I look at it like we want you to have as much information as possible so that you can make the decisions that best fit you and your family. It is not if people come in, well, I wouldn't abort anyway. That's great. That's awesome. But if your baby has a heart defect, the earlier you can find out, the more information you can get, groups, what hospital, you can meet with surgeons. I mean, it opens up this, I have more control and I can do something about it instead of when the baby's born, now we have a heart defect and now we're scrambling. So right. I look at all these ultrasounds like this. None of this is termination stuff. This is all, as sonographers and as a healthcare team, we are here to provide whatever the patient wants to do in her pregnancy. If the patient wants to go through, then we support that decision. If they decide to terminate, we also support that decision. So as healthcare providers, we are there for whatever the patient decides to do.
Yeah. So make your choice based on how you could get more information, not like your pro-life stance. That's what I always tell people in this situation, because it's just more information. And also, this doesn't entirely rule out a problem either.
Absolutely.
People can still have all these ultrasounds and then the baby comes out and you're like, whoa. How did we miss that?
Right. And there is like a certain percentage of babies with Down syndrome that will not show anything on ultrasound. So you can go through, and if you don't do, I know the NIPT is 99.6% accurate, but some babies don't show anything. So this never doesn't rule out everything. It's the best that we have though. And this is what we want to do with it. We want to give you as much information as we possibly can.
Yeah. Mm-hmm. Okay. Then let's move on to the big one. Well, it's not really the big one, but everyone thinks it's the big one because it could tell us the gender.
Yes. That anatomy ultrasound. Now I want to circle back. So some people do go between that 12 to 17 weeks and they do an entertainment ultrasound just for gender. That's great. I think that's wonderful. If you want to do that, great. That's cool. I'm cool with that. But the anatomy ultrasound, yes, it typically includes gender or sex, depending on how naughty or not naughty your baby is. But it really is like, this is the big one. I was at a conference a few years ago, well, probably 10 years ago now. And one of the doctors said if he could pick one test to do through the entire pregnancy, it would be an anatomy ultrasound. If he didn't have the choice to do blood work, it didn't have the choice to do any monitoring, the 20-week ultrasound would be his choice. He was also an OBGYN radiologist. So, he liked that part.
I might take blood pressure.
Right. But he was like, if I could choose one, this is it. But the fetal anatomy ultrasound. So this is the one that most people do find out their baby's gender at. And really
Wait, let me go back to entertainment ultrasound. Is that one you'd get at the mall?
I don't think they're at the mall. I don't think they're at the mall anymore. Now they used to be.
I'm so old. I'm dating myself now.
A few of them actually did used to be at the mall.
Yeah.
But I think we've kind of cracked down on those because those were typically done with people that were not registered sonographers. So they didn't have any experience. And what happened was people would think, well, I had an ultrasound. There might be a major defect, but that person, your skill that is not registered, not licensed, they'd miss things. So most entertainment ultrasounds are done by registered sonographers now.
Okay.
I don't know many companies that don't hire or don't have people that have gone through a program and that can prove that they know what's going on.
But would your doctor order that, or would
No,
you find that out on your own?
It's a mostly cash pay. You do that on your own. Now, some OB offices actually provide that service. For $50, you can come into your OB and do just a gender scan at 16 weeks.
Until they're wrong.
Well, I mean, I kind of appreciate the OB doing that because it's like if as a patient, you want to know and you're going to spend the money anyway, why not go to your OB who you trust?
Yeah.
A sonographer that you may already know is already skilled and you want to find the gender early. I actually am perfectly fine with that. And I feel like, great, I'm good with that. So I know that like we call it, the anatomy is like, most people refer to it as the gender ultrasound, but most people find out either by an NIPT, like the blood work, or they do an entertainment ultrasound prior to that. So,
man, I am old. I always waited for that. Although at Kaiser, they did this ultrasound between 16 and 18 weeks. So I always knew early with the two that I had Kaiser in California. So who knows?
Well, anatomy scans are typically done after 18 weeks. Now, if you're diabetic or there's an issue, you might do one earlier. So typically, though, is that 18 weeks. And a lot of people do wait for that. But there are some that don't want to. They want to do the gender early. That's fine. I'm here for that. I think it's great. And I'm glad that you go ahead and go do that. And then I'll do the hard stuff.
Well, and the more love and excitement you can have for your baby, like huzzah for that, because it's a very exciting and a big moment for your lives.
Totally is. And the more, if you want to know the gender early and if you feel more connected to your baby and your pregnancy, like I'm all for that. Like that's the whole point, is that you're happy and you feel more connected. So,
and that is a part of the ultrasound as well. Absolutely. We're not saying that it's all just one sterile medical procedure, but I think both mom and dad all of a sudden realize there is a human inside my body. Oh my gosh.
Totally. And when you have a good ultrasound and a good experience, that just increases that for the patient and their family. Absolutely. So yeah, I agree.
Okay. What do we see at the 20-weeker, 18 to 20 weeker?
So, some abnormalities are easier to see. Some are harder. Some are finer detailed. Some are trickier. Some don't show up until the third trimester. So we do our best with what the baby shows us. Sometimes if the baby is not in a good position, we may bring you back to recheck anatomy. But a basic detailed ultrasound includes the brain, the face, the chest, the heart, the baby's abdomen, the stomach, the kidneys, the bladder. We look at the umbilical cord. We look at where it comes inside the baby's belly, and we look at how many vessels there are. There should be 3. There are 2 arteries and 1 vein. We look at the spine. We look at the arms, and we look at the legs. We also look at the gender, even if you don't want to know. That is a part of your baby's anatomy, and we would like to see that is normal. We always do measurements. We call them the biometry. That tells us how well the baby's growing. We look at your placenta and the location of the placenta. We look at the amniotic fluid. Typically before 24 weeks, it's not measured. It's just subjective. Does it look normal? Does it look high? Does it look low? We always look at your ovaries. We look at your cervix. We obviously look at where the baby's positioned and how many babies are in there. So that's kind of your general overview of what we're looking at. And that's in a basic anatomy ultrasound, like one you would get done at your OB's office.
Yeah. And I've seen problems with all those areas.
All of them.
Some are big, some are not a big deal.
So, yes.
And some come out and there's absolutely nothing wrong.
Right.
Yeah.
Well, and some of this stuff kind of, we may see it at the anatomy scan, but by the time the baby's born, like it's gone. So sometimes we can see small little holes in the heart, but by the end of the third trimester, the baby has taken care of it and they're born without one. So it does happen that things look big at the anatomy and then slowly get better over time. So there's a lot of monitoring whenever we see something because we just don't want to assume like, oh, we see it now. It's probably not going to be a problem later. We do a lot of let's make sure it's still good. Let's make sure your baby's still healthy, which kind of leads me into follow-up ultrasounds. And this is something that we do them when we're monitoring the pregnancy. So this would be after your anatomy scan. Typically, it's after your anatomy scan. So for the baby, we might be monitoring the baby's growth. Is your baby big? Is your baby small? Are we watching baby's heart? Are we watching the kidneys? If it's a maternal reason, it's more like, are you diabetic? That can be pre-diabetic. That can be gestationally diabetic. Do you have high blood pressure? We monitor for your amniotic fluid, if it's low or if it's high. And we also, like if you have placenta previa at the anatomy scan, we want to watch that placenta and see that is it changing? Do we need to adjust your delivery based on the placenta location? So a lot of the later ones are kind of follow-ups because we're looking at something very specific. So that's different than your anatomy ultrasound. But we're always looking for like, how does the brain look? How does the heart look? Stomach, kidneys, bladder. We're always looking at that. And like the amniotic fluid, it's something that's constantly rotating through your baby, right? So your baby lives in a bubble and they eat, drink, and pee in the bubble. So when I see fluid in the baby's stomach, I know the baby can swallow. When I see fluid in the bladder, I know the tubes from the kidney to the bladder are open. And when I see fluid around the baby, I know your baby can pee. So we just eat, drink, pee all the time. Now, before 15 weeks, the mother's body makes amniotic fluid for the baby. But at 15 to 16 weeks, their kidneys start to take over that production. So we're always monitoring the kidneys because we want to know, okay, we got good amniotic fluid around the baby. The kidneys are working. We look like we're healthy and we're moving right along. So there's always things that we're looking for and evaluating for all throughout the pregnancy.
Yeah. And that's usually when I get the freak out ultrasound for my friends.
Yeah.
And a lot of those follow up ultrasounds is maybe because your baby's not cooperating. They can't see the 4 chambers of the heart.
Yeah.
Or there'll be like a shadow on something and they'll be like, we couldn't really tell. We want you to come back and hopefully your baby's in a new position the next day so that we can have a better view. Because, on a regular ultrasound, we just tell you to turn over, but your baby does not listen at all. Like at all.
They're in there living their best baby life. And just like kids, they do not care what we want. They don't care. They're like, I think I'll just stay right here with my hands over my face so you can't see my nose and my lips. They don't care, So there is a part of it, like if you cannot clear the anatomy, let's say it's your anatomy scan, and we cannot see the heart, we do not assume it's normal. We just have you come back. Baby gets a little bit bigger, gets in a different position, boom, we got all different pictures. And I personally like in anatomy scans and follow-up scans, I want your baby moving. I know it sounds crazy, like I don't want them flipping all over the place, but every position your baby gets in shows me that that's normal, right? So if your baby's right and then we're left and then we're breech and then we're transverse, like I want to see your baby looks normal in every position. So when they move around a lot, I can see multiple positions of the baby. So I would like them to move and then hold still, right? Like move, pause. That doesn't always work, but that's my ultimate goal. So, but sometimes babies just don't move and we just will not clear it if we can't see it. It's very simple. Like we never assume. We want to see it. We want to see that it always looks good and that the baby remains healthy. Always.
Yeah. So I always tell people, ask, like, was this just because the baby was in a funny position or are you seeing something that made you nervous? Right. Because sometimes they're just like, we're going to have you come back for a second one. And that's not helpful.
Right. It's not.
Because
but if it's explained
just ask
to you,
those things.
Right. If it's explained to you, hey, I can't see the heart. So we're going to just have you come back. And I try to tell my patients, I don't think there's anything wrong. It's just a positional thing. I'll try to give them that, especially if they see that like my detailed exams, they take an hour to do for a maternal fetal medicine practice. So if I've tried for an hour and I cannot get your baby's heart, we're done. We'll have you come back in 2 weeks. But I feel like that should be well explained to you, the reasoning. And as a patient, if you see it like, boy, that baby didn't roll over, then you kind of understand the need for it as well. So it's important to ask. A lot of times when patients come in for their follow-ups, I like to ask them, so what is your understanding of today's appointment? And that kind of opens up for the patient to say, oh, well, last time we didn't see the heart. Oh, that is also my understanding. Okay. So it's kind of nice to get a patient's perspective before I come in bulldozing with what I think my reason is. Does that make sense?
Yeah. Versus they just told me to come back.
Right. So I want you to think about it. I want you because being knowledgeable is empowering in your pregnancy. Being aware of what happens in your pregnancy, why you need certain tests. It just gives you more information and it gives you more empowerment. You're just that knowledge itself. And I think as a patient, as you have that, I think it's better for you.
Yes, for sure.
So, yeah.
Because then you don't worry about needless things about like your baby's just obstinate. Good luck.
Right. Or, like if it's a growth issue, then okay, my baby's small. I'm looking for this thing. This is why antenatal testing is so important. This is why it's important to come to my ultrasounds. Or I'm diabetic, so I know I have to watch my sugars more. It's knowledge of just the health of you, the health of your body, the health of your pregnancy, the health of your baby.
Yeah.
And that kind of leads you into, then you can understand why the next parts are so important.
Yes.
So I think it's a big deal.
And Marybeth and I were talking about this in advance. A lot of times, maybe your doctor will say, we didn't see the heart very well, but all you hear is something's wrong with the heart. And if you get home and you're like, I literally have no idea what they said, like sometimes then my husband will be like, well, what did they say? And I'll just be like, heart. You only remembered one word. You can always, call back, say, I just didn't understand what was explained. Or if your appointment's in the next couple of days, maybe they just, wait for that. But, if you've had like a counseling by the provider and then you have no idea what was said, and then again, you're turning to people on Instagram and TikTok, maybe call your provider, ask them. They want you to understand what happened, and they understand that sometimes it's just a fog, especially if it's a big deal.
Absolutely. And I think it's important that patients feel comfortable telling their providers, I just need you to explain it to me again, or I didn't quite understand it. You should never feel bad reaching out again and asking for more clarification ever. And I think isn't there some statistic that we only remember like 30% of what is said in a visit? It's some kind of statistic. I'd have to look it up. So if you get big news or what you think is big news, I think it's hard to understand and retain all at one time. So I think it's perfectly normal for people to come back and say, please explain this to me again. Or I don't quite understand it. Could you explain it in a different way? I think you should always be able to do that with your provider, always.
Yeah. And if you can't talk to like the perinatologist, maybe you don't have their number or whatever, you can call your OB and they most likely can explain it. Or if they have any questions about how to explain it, they can call the perinatologist as well. So you have lots of providers that you can reach out to, and definitely reach out because they want you to understand this. It's not like they didn't just walk in the room and say heart and walk back out, even though that's all that you understood or took in, which we totally get. These are big, overwhelming, life-changing things sometimes. And a lot of times they're not, just FYI.
Yeah.
I have so many people freaking out from ultrasounds that I'm like, let's just wait. Yeah. So
very true. And I think really like of all the pregnancies, congenital abnormalities only make up 3% of pregnancies. That's the latest data. So yes, typically it's not a big deal, but sometimes it is. But you should know, like statistically, it's actually very low.
Yeah. And so many are super, super fixable. It's amazing.
Oh my gosh.
What they can do.
Right. You got an extra finger? We'll take care of that. That's no big deal.
It's amazing. Yeah.
Yeah, it is. Yeah.
All right. Well, I'm going to let Marybeth go right now, but stay tuned. In 2 weeks, we are going to talk about testing, which is going to be awesome because as you get into your third trimester, you may see that ultrasound tech more than your husband. So
absolutely.
Thanks for coming on, Marybeth.
Thanks.
Okay, guys, I hope you liked that episode. I thought it was so helpful to talk about what to expect in an ultrasound because I think all of us just kind of think heartbeat, gender, but there's so much more that they're looking at and can tell us. And just like she said, like from when I started labor and delivery until now, like the ultrasounds are night and day about what can be seen on them. Now, the ultrasound at your provider's office may not be that good, but the ultrasounds that techs use in big offices are amazing. Be sure and stay tuned for part 2, which will run in 2 weeks. Where we're going to talk about like third trimester testing. And next week, we've got a fun one coming up about what to do when you are really mad at your kid. So always a little something for everyone here on the Pulling Girls podcast. Thanks so much for joining us on today's episode. We know you have lots of options for your ears, and we are glad that you chose us. We drop episodes weekly, and until next time, we hope you have a tangle-free day.